for various journal, and her special interest is in patient safety and regional anesthesia. May I request Dr. Raj Tobin to deliver her talk.
Thank you, Dr. Bhardwaj.
Good morning, everyone. At the start, I would like to thank Dr. M.D. Kaur and Dr. Neerja Banerjee for extending this invitation to me to be part of this very prestigious and much awaited academic event of the year. So I'm going to be speaking on anesthetic concerns for robotic surgery. So just as India's problem with Ukraine, we have several challenges. The challenges of the robot. We have to address the comfort zone of our surgical colleagues, and at the same time, we must administer anesthesia very safely to our patients. So in this lecture, I will cover these problems in three parts. One is a problem specific to the use of robot for a surgery. Problems of positioning, whether steep Trendelenburg position, semi-prone, oral surgery and such. And then problems specific to patient, as in any other surgery, but of special concern in patients undergoing a robotic procedure. So first of all, you can see from this picture that the anesthetist is sitting appreciably far from the robot, and this is a console. This is where the chief surgeon is. So first challenge is, of course, the remote access. Second, our IV lines are all concealed. So in case you have a central line, at least this part is to an extent accessible to you. However, all the IV lines which are under the drape, as in any other surgery, should be secured with a lower lock connection. You should have minimal connections under the drape, which are not within an easy access. And whenever you give over to another colleague during the surgery, then that anesthetist should know exactly where the connections lie. And this is a very important part of the handover procedure. Then the second part is, of course, endotracheal tube. Again, as in any other surgery, it should be secured well. You're far away, so you use a tube board and make sure that the tube is positioned in such a way that there is minimal chance of the tube getting kinked. More so when the head end is not on our side. In many of these cases, the urinary bag is not accessible, for instance, in robotic-assisted radical prostatectomies and in renal transplants. So here, we have to constantly monitor the hemodynamics, the fluids that we have given to the patient, the lactate levels, because even in a 5 to 6 hours long surgery, we may not be able to see the urine output of the patient. Then, of course, these are very expensive surgeries. So we do not have the leisure of postponing a surgery once the robot has been docked, right? Because there are single-use consumables and cost is almost up to a lakh of rupees. So we need to work up our patients really, really well so that we don't really call off the surgery in the middle of the case. It shouldn't be done in any other case, but more so in these patients. And of course, these surgeries go over a very long duration of time. So our preoperative workup should be such that we are comfortable and the patient is safe during the duration of the surgery. The very important part of a robotic surgery is that docking and undocking both take time. So, the undocking takes at least 5 minutes because the robotic arms come out one after another. So if there is any major adverse cardiac event, or there is anaphylaxis or any such challenging event for us, then the response time gets prolonged, and because the access to the patient takes time. And that is why for all the teams who engage themselves in administering anesthesia for robotic procedures, there should be a drill conducted at regular intervals. And many of them are now available on YouTube, and you all can watch it. That how do the teams respond if there is an event? So what is the role of each team member? How are the arms undocked? And this is absolutely a must for any team which undertakes robotic surgical procedures. Now, other issues are positioning. Now, there are all kinds of surgeries which are done. Some are short duration, supine or reverse Trendelenburg position, still not such a problem. Even short duration surgeries like black pulleys and hernias are being done today, or pyeloplasties. Then there is an impact of steep TP position. So we must keep hemodynamics and ventilation in our minds. We always evaluate the posterior chamber of eye in patients who are uncontrolled diabetics or uncontrolled hypertensives. We've of course optimized them to some extent before surgery, but the impact has been there over the years. So the posterior chamber of the eye should be evaluated. Patients with glaucoma, with history of laser surgeries for retina, all of them should be seen by an ophthalmologist, and any defect in vision or whatever is the finding should be clearly documented in the patient record. And you should have a copy of that in the file. Some of us are lucky where we have an electronic health record, but otherwise this is absolutely mandatory, so that tomorrow the patient does not come and question you or blame you for anything. Because in steep Trendelenburg position, the head is considerably low, almost touching the ground. So obviously the intracranial pressure and will go up. There will be optic nerve sheath diameter will go up, and this can have an impact on a patient who already has compromises in this area. And then, of course, the padding. So here you can see, as any patient in lithotomy positions, here we are using Allen stirrup. You can see the excellent padding for the peroneals, so the patient doesn't wake up with a foot drop. Similarly, we must make sure that there's no stretch of the brachial plexus. We never ever tie the hand to anything, because when the patient is taken in a head low position, so they can be, if you have tied the hand, there will be severe stretch and patient will wake up with palsy of any of the cords or brachial plexus. In a patient who has who gives a history of having undergone joint replacement, or who has arthritis, any kind of deformity, we must evaluate them for permissible range of movement before positioning. These such patients, if it has been missed in the PSE, please look at and ask the patient before induction about what movement is totally easily permissible, so that you do not cause any harm to the patient. These are also very expensive surgeries, right? Joint replacements. So then, of course, another aspect, as I said earlier, is positioning and cushioning of parts. So we use this mattress in our we use this mattress during positioning in our hospital. So I'm not advocating that it should, but since we started using it, I really don't know which company it comes from, but we have not had any patient waking up with tingling in numbness. You can see the excellent padding at the shoulder, and this maintains. This is a further support here at the neck. So that there is no drag, there is no movement of the neck during positioning, the twisting and turning of the head. And then the patient is encased from the side. Both the arms are tucked in again, the palm facing inwards. Patient is nice and secure, and this is what this mattress looks like. There is no challenge to intubation when the patient is placed in this mattress. Ryle-Stoop is a must in a patient who has to undergo robotic surgery in steep TP position. Place it, check it, and attach it to a bag, because you really don't want a mess at the head end. The reason is then when patient is in that position for such a long time, gastric juices will collect, and then they may trickle down, more so in a patient whose lower esophageal junction is not working very well. And it can, if it trickles into the eye, then there is a high potential for conjunctival injury and loss of vision. So eye should be taped. We use a tegaderm, so that it is watertight, and then we pad it. So eyes should be protected from spillage of acidic gastric secretions. In transoral robotic surgery, as I said, the now robots are being used in all kinds of surgery. Safety goggles for patient, molded dental guards, reinforced or laser tube, nasal intubations where required. We even use robots now for doing mediastinal surgeries. In thoracic surgeries, we prepare for single lung ventilation, and because the surgeons may kind of raise the arm considerably for the surgical access, so we have to strike a balance between a good surgical access and stretch on lower odds of brachial plexus. And we must also watch for injuries from robotic arm. So you should know the range of movement of the robotic arm when we position the patient. Then there are issues specific to the patient. Well, these issues are similar to our preparing a patient for any other surgery, but some of them have a higher impact in robotic patients. So I'm going to touch upon them. One is optimizing comorbidities. We follow ERAS protocols. Now the ERAS protocols for practically every kind of surgery, robotic, otherwise, even different types of robotic surgery, whether gynecological or urological, and they should absolutely be followed in cohesion with your surgical teams. Cardiac evaluation where required, focus assessment of diabetics and those with poor effort tolerance or limited mobility, or patients who give a history of diabetic undergo a cardiac evaluation, irrespective of whether they have any cardiac complaints or not. Evaluation for OSA and a plan of action, all that. So maybe the patient is already is on CPAP machine, so you can ask the patient to bring his or her machine from home. You can use the one you have in hospital, but they are a lot more comfortable when they have their own machine with them. Explain ICU stay in all these patients and explain post-operative ventilation. So as you move up your learning curve, today we send almost, I think, 75% of our patients to rooms. We don't send them to the ICU unless they are, cancer patients with considerable surgical dissection or considerable length of time. But most of them go to the room, but we always take a consent for ICU stay. And of course, informed consent, explaining everything, including the lines, and as I said, about a visual examination. We must plan a perioperative thromboprophylaxis because these are very long surgeries. So where required, we give preoperative low molecular weight heparin. Where it is contraindicated, you can use mechanical thromboprophylaxis and then initiate chemothromoprophylaxis as early as possible in the postoperative period. There should be a proper plan of care for this. And there should be a focused assessment for DVT in obese patients, those with very large pelvic mass and history of deep vein thrombosis. Plan for intubation. Now, this is another very, very important part in a robotic surgery, more so when the robotic surgery is being done in a head-low position. It should be as atraumatic and smooth as possible. If you are anticipating that you may take multiple attempts, so it's tad difficult, but I will try it. If I can't, then maybe I'll put in a bougie, or then maybe I'll use a visual laryngoscope. So they should be skilled anesthetists at the site, because if you cause too much airway trauma while intubating the patient, then this can give rise to a horrendous extubation phase where patient will wake up with a lot of airway edema, and you may not be, and there may be a scenario of failure to extubate the patient. So do not hesitate to plan an elective fiber optic intubation instead of going ahead with a trial and error kind of technique. We can use TIVA. You can use, and the combination that mostly is being used is anti-Salagog, because we want the oral cavity to be dry. We don't want the tube to slip out. We don't want too much drooling and saliva. We can use short-acting opioid like fentanyl. Nowadays, we are, so I'm not a proponent of opioid-free anesthesia, but yes, the usage is much less in our practice. Propofol, atracurium or cisatracurium or norvecuronium. Infusion is advised, as any small movement can cause serious internal injuries to the patient. So even if it is a very small surgery, we always run an infusion of non-depolarizing agents, and of course you can switch it off at the end of the surgery and wake up the patient. Oxygen air mixture, nitrous is not used, again because of the pneumoperitoneum involved in these cases. Dexmed infusion is used very often in our practice, and I think in most of the hospitals who are doing these procedures with robots. For the intraoperative monitoring, standard pulse, BP saturation, ATCO2, airway pressures, temperature. So they kind of okay if we are doing a hernia or lap chole or a pyeloplasty. But in any surgery where suppose it's a morbidly obese patient with a difficult access, or we feel that we may need a central line in the post-operative period for if you're doing a major GI surgery, then we'll put in a central line. Invasive arterial monitoring, one, because we need to monitor the blood pressure. Second, because we like to look at the lactates. And we can do an ABG in these long cases to know the PO2, the PaCO2, etc. NIBP we usually keep as a backup unless it's a surgery of about 2.5 hour duration. You can have short duration robotic surgeries. But the problem with NIBP is that even if you put it at 5-minute duration, and if the surgery goes on for something like 5 to 8 hours, that goes on and off. You can imagine every 5 minutes, the patient wakes up with a terribly sore and painful hand. And more than the surgical pain, the patient complains of pain in the arm. And it sometimes takes up to 24 hours to go away. So in order to avoid that anguish to the patient, I much prefer that we put an intraarterial line. Endotracheal cuff pressure monitoring and optic nerve sheath diameter. So we don't routinely use optic nerve sheath diameter. I don't think in most of the centers use optic nerve sheath diameter as a routine procedure, but yes, it can be used. This is a slide to show you. The first image is pre-induction. You can see the time. It's been taken at, I think, 8 o'clock in the morning. And the second image is after 3 hours in the same patient. So this is the retina, and we mark a point for standardization. It's at a distance of 0.3 centimeters, and that is where we measure. You can see the two cursors, and here the diameter is 0.38, and here after 3 hours, the diameter has increased to 0.51. So an optic nerve sheath diameter of 0.5 centimeter predicts an ICP of greater than 20. So this is one way of monitoring the intracranial pressure, or to forecast that, okay, this patient may require ventilation in the head position for some time before the edema recedes, and then we may extubate the patient. Restrictive fluid strategy. As you know, we don't want to get into a cerebral edema situation in steep tendon block position. We do not want a flooding of field in robotic assisted radical prostatectomy. Surgeons don't like the field getting flooded because the bladder is open, and of course we don't want too much fluid in a GI surgery because we don't want the gut to be the intestines to be soggy. So yes, it's a restrictive fluid strategy, more so in cases where there are other challenges, like a patient with CRF. Perform a leak test before extubation in patients, especially where you have had taken a couple of attempts for intubation or it's an obese patient. Consider delayed extubation or an airway exchange catheter for extubation. Our strategy is that we gainfully use the time after undocking for reversal. So the moment they undock, we make the patient supine. We give a little bit of leg up, for the venous drainage, and we bring the head up by about 35 to 40 degrees, allowing the edema to drain. We can consider steroids in obese patients in steep TP position. So this is another challenge of robotic procedure, especially in obese patients or in patients with end-stage renal disease. You can see this is the uvula, and you can see the whole pharyngeal wall collapse. So such patients wake up fully alert, awake, responding. You extubate the patient, and within a couple of minutes, the patient retains CO2, stops breathing, desaturate, and you land up intubating the patient again. So any such patient where you expect that there can be an issue like this, it's a good idea to put in a FROVAS, intubating, ventilating Puji. Alternatively, one can use a soft silicone nasopharyngeal airway, and just so it bypasses this obstruction. And actually, this edema recedes very quickly. Within an hour or hour and a half, this settles down completely. So you must use Otrivin and lubricate it well, because you do not want to get into a messy situation where there is bleed from the nose. So you kind of put Otrivin, use lubrication, dilate the nasal slice gingerly with your finger, and then insert the nasopharyngeal airway, and that usually serves very well. Many people earlier, not now, but earlier we used to sometimes shift from endotracheal tube to LMA or ProSeal, and then wake up the patient after ventilating there for some time in the OT. We can consider shifting to adjacent OT. So there are times when you have 3 to 4 robotic cases listed, so surgical teams are in a hurry to put the next case. So we can use the adjacent OT, shift the patient there, and take your time to extubate the patient in an unhurried fashion, while the robotic OT is used for induction of the second case. Before reversal, we can give sonosite guided blocks like TAP, either side, rectal sheath block. It's all depending on the ports, or a 4-quadrant TAP like we give in kidney transplant patients, paravertebral block, or quadratus lumborum block. One can use NSAIDs if there's no contraindication, and paracetamol as part of multimodal analgesia. We rarely ever use epidural in robotic. The only indication probably is when we are doing a case where the surgeon says that, well, there is a chance that I may open up the patient, or there's a chance that I will take the specimen is so huge that I will be giving an incision to take out the specimen. So if there's a case like that, then we may put in an epidural in this patient. PCA with fentanyl on bolus mode with lockout. We have been using this for almost 6-7 years now, even in our kidney transplant patients, and it's very safe, and it can be used with this minimal usage of fentanyl. So combination of abdominal field block with a PCA with fentanyl keeps the patient very happy in the postoperative period. Of course, this goes without saying, as in other surgeries, incentive spirometry, non-invasive ventilation if required in obese patients, early mobilization, good hydration, and early enteral feeding. And of course, chemothrombo-prophylaxis, which I touched upon earlier in this lecture. So this is a patient. This is when in our very early days, several years ago, when we did not have that very nice encasing mattress that I showed you earlier. So it was very difficult for us to position such patients, and we have had instances of patient waking up with, tingling and numbness in one of the fingers or a part of the hand. So the game is all about good position, because these patients are very difficult to position, and they stay. It is our responsibility that we do not cause any harm to such patients, because it also prolongs their cost. You get a neurology referral, or you get a nerve conduction study done, or they stay with us for 1 or 2 days, and it translates into cost. So that's not really good. So a few studies to touch upon the advantages of robotic surgery. So this is a study published in 2015 in a journal which has an impact factor of 2.05. So we see that robotic-assisted radical prostatectomy leads to comparable perioperative and pathologic outcomes to non-morbidly obese patients. So an obese patient was always a challenge even when we started, because once the problems of obesity, then we are giving pneumoperitoneum, and we're keeping them in a steep hydro position for anything between 5 to 7 hours. And they found no difference in the ability, so there was no problem surgically in performing nerve sparing or pelvic lymphadenopathy or the length of stay. This is the second study in a high impact journal, which says that no differences in terms of length of hospital stay, blood loss, complication rates, numbers of pelvic and para-aortic lymph nodes retrieved, or recurrence in survivor. This is another, again, same journal, which says that only age was, so this is a big cohort, 1,000 plus patients. Only age was significantly associated with a higher risk of pulmonary complications. Older age, higher estimated blood loss, and longer case length were associated with a higher rate of all-cause complications. So no impact of obesity in patients undergoing robotic surgery. This is one study which says that we should not deny robotic surgery to morbidly obese patients, because BMI is not a good way of assessing or judging a patient. Waist hip ratio and waist circumference are more sensitive markers for central obesity. They may better indicate risk associated with obesity with robotic surgical outcomes. So this is a single center retrospective review, single surgeon. Primary hypothesis was that patients undergoing robotic hysterectomies would have increased incidence of postoperative pulmonary complication because of the steep head low position and the abdominal content pushing on the lung, causing basal atelectasis, difficulty in ventilating. But the study revealed that they did not result in an increase in cardiopulmonary or overall complications when in robotic hysterectomy, where TH versus obese and non-obese. So what is a very important concern in this cohort of patients, obese undergoing surgery in head low position? The most important concern here is ventilation. The strategy should aim to prevent lung over distension, volume trauma, de-recruitment, atelect trauma, and dysfunctional inflammation, which is biotrauma. So when we talk about airway pressure, what does airway pressure do? So this is the airflow which is going into the lung. It causes expansion of the lung, and it also expansion of the chest wall. In a healthy non-obese patient, 60 to 70% of this airway pressure goes towards lung expansion, and 30 to 40% goes towards chest wall expansion. So now look at this picture here. What is transpulmonary pressure? So we worry about this pressure because this is the pressure which is acting on the lung, which has a potential to cause barotrauma. Now, transpulmonary pressure we get when we subtract pleural pressure from the airway pressure. We can see the airway pressure on a monitor, but we don't know the pleural pressure. Now, in one of the studies, they used esophageal balloon manometry as a surrogate for pleural pressure. So you can calculate the transpulmonary pressure from the airway pressure and the pressure shown by esophageal balloon manometry. The other part, so I will come to this again later. So other problem of these patients is the pressure exerted by the abdominal content when the patient is in head low position. So there's a concept that you must understand. There's something called dynamic hyperinflation, which is caused by lung regions that are unable to deflate to normal volumes because of the obstructed flow caused by small airway collapse. So there's a push from down, so the small airways collapse before the air has gone out. This is different from true hyperinflation like that seen in emphysema, where expiratory flow limitation leads to higher than physiological lung volumes. In the obese patient, it is a reduction in physiological lung volumes that leads to this dynamic hyperinflation. Force of body mass collapsing lung tissue also collapses airways. So, it is pushing from down, and this results in air trapping and autopay, but does not generalize hyperinflation. So it is only in this part, the lower parts, but there's no generalized hyperinflation. So in this is published in 2020, it says that they took the pressure when after induction of the patient. So they found that there is remarkably worse stiffening of the chest wall, greater than 300% than of the lungs, approximately 50% in the surgical stage of TP position, with docked robotic arms as compared to measurements immediately after intubation on all BMI categories. So, once they docked the arm, they found that there was considerable stiffening of chest wall. So this study says that absolute limits for airway plateau pressure, such as 30 centimeters of water, are not necessarily accurate during robotic surgery, as a substantial fraction of airway pressure is not applied to distend the lungs, but to expand this stiff chest wall and stiff and rigid chest wall. So overzealous limitation of PEEP or tidal volume to maintain a plateau pressure less than 20 to 30 centimeters of water in such cases could expose patients to unnecessary hypoxemia, hypoventilation, and mechanical injury. So, so earlier we used to be always scampering that, oh, pressure is going up to 35, 36, keep the tidal volume low, keep the tidal volume low, and that doesn't really work. So now, even if you find a pressure of 35, 36, it is not worrisome, because the main target is that we should be able to ventilate the patient well, ensure oxygenation, and wash out of carbon dioxide. In the study published in 2018, the authors said that we believe that peritoneal insufflation attenuates the effect of high airway pressures by raising intrapleural pressure and reducing the gradient across terminal bronchioles and alveoli. Transpulmonary airway pressures remain static. This reduced transpulmonary gradient attenuates the strain on lung tissue that would otherwise be imposed by ventilation at high pressures. And that is what we see in our practice also. This is a very important conclusion, as this takes a lot of fear out of our minds when we see high peak and plateau pressures. So they said that, authors say that patient positioning in fixed steep tendon block position and peritoneal insufflation in radical hysterectomy can make the implementation of recommended guidelines challenging, if not impossible. And we really don't see patients, even when the airway pressures are peaking to 36, 37, when we're doing 6 surgeries, we really don't see patients waking up with barotrauma. So there's no golden ventilation strategy. So choose what works for the patient and meets the saturation and end-tidal CO2 goals, keeping an eye on the pressure. So with this slide, I end my lecture. And if there are any questions, I will take them at the end of this presentation. Thank you once again for your time.
Thank you so much, ma'am. Sir,
Thank
would
you.
you please, I invite you to conclude the session.
Yes. Can we invite questions from the audience?
Sir, as of now, there are no questions.
So do you use monitor patient with BIS monitoring?
No, we don't.
Because we are using TIVA and okay.
Yeah, when we use TIVA, we use BIS. We published a study also on TIVA, but we don't use it routinely. There's one anesthetist who is very fond of using TIVA. So when she uses, then she may put the BIS. But otherwise, most of us don't use TIVA.
Another article which I read from British Journal of Anesthesia, it appeared in 2015, and the article was about complications which are distant from the site of surgery. So that was very interesting article, and I would request all the audience to go through that article. Thanks, Dr. Raj, for a beautiful presentation.
Thank you.
Back to the organizers.
Thank you.
Thank you, ma'am, and thank you, sir.
Thank you.
Thank you. Thank you very much. Thank you, organizers.
Thank you, ma'am.
Thank you, everyone.
Now we'll move on to the next presentation, which is much awaited, based on the drug Viva. The drugs which will be taken on are neuromuscular blocker and reversal agent. So I would like to introduce the examiner.